Dr. Shen, I'd like to say thank you for joining me today to talk a little bit more about the paper that we wrote together, looking at the use of apalutamide in elderly men with prostate cancer. Um, First, can you talk a little bit about the studies that led to that paper, specifically Spartan and Titan?
Absolutely. Thanks for having me. It's a pleasure to be here. So these were two, separate studies, large phase 3 randomized studies. Titan looked at a patient population with metastatic castration-sensitive prostate cancer, who was double-blind, placebo-controlled. And Spartan was a phase 3 randomized study looking at non-metastatic, so M0 castration-resistant prostate cancer. So it's important to know that this was a combined analysis looking at two separate large phase 3 studies. They're open globally. Each enrolled over 1,000 participants from over 20 countries. And there was a long duration of follow-up. So the data was really put together after the final analysis. And in Titan, the median follow-up was about 44 months. And in Spartan, it was about 52 months. So we had a lot of data pertaining to these participants in this study.
That's wonderful. Thank you. Would you expect a big difference between patients who are newly diagnosed metastatic and those that have non-metastatic CRPC?
I think in terms of the patient population, those that have a new diagnosis of a metastatic castration-sensitive disease are generally, novel to treatment exposure, being ADT or second generation agents such as apalutamide. Whereas your non-metastatic or M0 castration-resistant patient population, they're pretty familiar with what ADT looks like, how it feels in their bodies in terms of the side effects of fatigue, hot flashes, what have you. So in terms of the actual exposure to ADT, we did see some differences between the two studies.
Thank you for that. So the company ran these two big studies, and then you and I talked about, well, can we look at patients 75 and older and see how they did on apalutamide? Why is such an analysis a good idea or not a good idea, whatever you think?
Yeah, so my training background is as a medical oncologist, but also as a geriatric oncologist. So I kind of have a unique perspective on things. Older adults with advanced prostate cancer, they really do have unique needs and circumstances, right? They may have more comorbidities or more medications on their med list. And we do have a paucity of data when it comes to older adults enrolling in therapeutic clinical trials, both in prostate cancer and other malignancies. So I think it's incredibly important that we take the opportunity to look at, this existing data more closely when it becomes available.
Thank you for that. And I would add that sometimes in my experience, I see that elderly men, maybe in their 80s, are not offered treatment. And that our analysis shows that they probably should be.
Yeah, we'll probably go into this in a little bit, but when you looked at the baseline characteristics, for example, in the Spartan study, so the non-metastatic M0 CRPC disease setting, we did see that in general, there was a trend towards a little bit higher of a performance status, suggesting some functional decline. We also did see a higher median, PSA level, potentially people holding off on offering these types of effective agents in an earlier setting. And also a longer median duration of that time on ADT for the older patient population.
What do you think about where we divided the age? Like, why do we pick the splits that we did?
Yeah, so we in the manuscript, we actually looked at two different breakdowns. One was kind of a 3 different group, less than 65, 65 to 79, and then 80 or older. So in that breakdown for Titan, at least, we saw about a third were less than 65. The majority, so 60%, were in that middle range, 65 to 79. And then a very small percentage of older adults, 9% were 80 or older. And so again, this is kind of the mindset of when you have a newly diagnosed patient with metastatic castration-sensitive disease, if they're in their 80s or 90s, even potentially, that discussion of participating in a clinical trial, I think, comes up, right? Because only 9% were really representative of that patient population. But even when we looked at the data cut at a binary of 75, so less than 75 or 75 and older, 77% were still less than 75%, 75 years of age. So, within that, we are still treating a lot of men with, newly diagnosed stage 4 disease that are 75 and older. And that being said, not a lot of that is represented on these large clinical trials. So I think that's one important thing to highlight, is that we need more. We need to have those conversations with those patients and their families and encourage it, because they may derive benefit.
Wonderful. So how did you look at the data for this ad hoc analysis of the elderly patient population? What were the important endpoints you looked at, and anything else?
Yeah, so for me, I wanted to, of course, look at the primary endpoints of the two studies. So for TITAN, that was radiographic progression-free survival and overall survival. And then for SPARTAN, that was metastasis-free survival and overall survival. So kind of your hard clinical outcomes. And you'll see in the first figure of our manuscript that the forest plots very clearly show that, all subgroups are benefiting, with this caveat that in that TITAN group, a very small percentage of 80 or older patients were accrued. But it's a very clear, trend towards the left, right? And then on top of that, other outcomes that are important to older adults include, patient-reported outcomes, how they're feeling, health-related quality of life, and that was measured with FACT-P. What I thought was interesting with the FACT-P data are kind of on two ends of the spectrum. So when you looked at the TITAN data and you had your younger patients getting either apalutamide or placebo in addition to ADT, you actually saw some worsening in the placebo group. So that suggests to me maybe under treatment of younger patients, their disease giving them more symptoms, and getting ADT monotherapy is not something we generally do anymore. So I think that was an important difference to see. But also on the far end, potentially in older adults, there was a slight trend towards some change in the health-related quality of life. Again, the numbers were small, but as older adults, they may be more mindful or sensitive to certain hormonal changes with the addition of a second-generation agent. And then the last component that we looked at in terms of outcomes was the treatment-emergent adverse events. And it was important that, in general, we did not see a significant difference in those.
Looking at your background in geriatrics, which is a very unique background that you have, is especially important in prostate cancer, which affects elderly men typically. As a physician and as an oncologist and a gerontologist, what do you think of before you offer people treatment for their prostate cancer? Like, if you just look at their chart and it says they're 89 years old, have you already made up your mind about whether or not you're going to give aggressive therapy?
Yeah, so I think that as a general oncologist, probably some people have some bias when they see that first number, right? It's the first thing you talk about when you're presenting a patient. But to me, functional age is by far and away much more important than chronological age. So, right after I look at that age, I also look at their medical history, right? Is this an 89-year-old that has a whole slew of, coronary artery disease, atrial fibrillation, COPD? Or do they just have, well-controlled hypertension and they're very active, they might be still running, 3 times, 5 times a week. And so I think it's an important balance to make sure we're at least having that discussion and adequately treating our older adults. And that goes both ways, under treatment and over treatment. So I think it's important to kind of give them the landscape of what treatment would look like for a healthy, functional older adult. And then help them make an informed decision about what's best for them. Sometimes there's other limiting factors like, comorbidities, diabetes, potentially you need a steroid-sparing regimen. Potentially there's drug-drug interactions with, for example, an anticoagulation. So these are things that I always take into account as a person that takes care of a lot of these older men.
Thank you for that. And you mentioned I think you said functional age. Is there like an equation to figure that out for us who are not trained?
Yeah, there's a lot of models. A physician gestalt really puts it down into ECOG or Karnofsky, right? It kind of summarizes everything into one single digit. But the reality is, and I think many of us would admit this, is there's a lot of subjectivity to that assessment. So really things like really assessing their comorbidities. If you're able to, assessing things in the clinic like their gait speed or the hand grip strength. These are things that as geriatricians, they do all the time in their other clinics.
Mm.
But, as oncologists, we're strapped for time. We have very short slots of patients. And so we're not able to do that full geriatric assessment. So my general recommendation is if you're embedded in a health system or somewhere where you can leverage and integrate a geriatrician in their care, I think that would be best.
That sounds very wise.